Hi, dear colleagues and friends, welcome to the webinar. COVID-19 pandemic is ongoing, even though the vaccination has been developed. Today, we will discuss on cardiovascular prevention during and after the COVID-19. I will hand over to a chairperson, a special guest from Argentina, Professor Daniel Pinheiro, the president-elect of the World Heart Federation. Professor Daniel, please.
Thank you so much, my friend Koji Hasegawa. For me, it's a high privilege to share with you your evening and my morning. So thank you so much. It's a real pleasure and a real privilege. Let me introduce now the cardiovascular prevention during and after the COVID-19 pandemic. This is a meeting organized by the International Society of Cardiovascular Pharmacotherapy and the Asia Pacific Health Network. Today we have 4 speakers with the highest level in cardiology worldwide. We'll have the first conference with Dr. Gheorghe-Andrei from Romania, then Dr. Koji Hasegawa from Japan. The third speaker would be Dr. Jyoti Jo from Singapore, and the last will be Dr. Mongo from Mongol. Again, it's a pleasure, and I will go directly to the first speaker, Dr. Gheorghe-Andrei, Professor, Head of Internal Medicine Clinic and Cardiology Department of Colentina University Hospital in Bucharest, Romania. Dr. Dan will address the topic of cardiovascular complications associated with COVID-19. Thank you, Dr. Dan, to join us.
Dear friends, dear Koji, dear Daniel, good morning in Argentina, good evening in Japan, in Mongolia, and good afternoon in Romania. My task today is to talk in a short time about the COVID-19 associated cardiovascular complication. As you can see from my first slide, this is not important, this is my first slide. It is not an easy task because today I have looked for references about COVID-19 cardiovascular in the end of 20 and the beginning of 2021, and you see I have already 5,300 papers. I should resume in 10 minutes. It will be not easy, but I will try to remind you the general that the COVID-19 virus has a tropism to the AC2 receptor. The AC2 receptor in physiologic situation is responsible for the synthesis of angiotensin 1,7, which is a vasodilator and anti-inflammatory, opposing to angiotensin 2, which acting on the 81 receptor is vasoconstrictor and pro-inflammatory. This means that when the virus is linked to AC2 receptor and is primed to the receptor but by a transmembrane protease serine 2, it enters the cell, it destroys the cell during multiplication, but in the same time, an inflammatory innate immunologic response is born, which activate the ADAM17, which is a disintegrin metalloprotease 17, which is responsible for the shading of the AC2 receptor for from the surface of the cell. The net result is a decrease in angiotensin 1,7 and of the density of the AC2 receptor, and increase in angiotensin 2 with a net pro-inflammatory response. Obviously, this has important consequences on the myocardium, and I have chosen three important targets for my discussion: myocardial damage, thromboemboloendotheliopathy, and arrhythmias. Let's begin with myocardial damage. There is a continuous controversy regarding the pathways by which the COVID-19 could influence the myocardium. As you can see from this synoptic figure by Atri and co-workers, there are many ways in which COVID could interfere with the myocardium. Some are indirect, like the oxygen mismatch because of lung involvement or because of the endothelial injury. Some are direct, like stress cardiomyopathy or direct viral toxicity, and some are mixed, like the inflammatory state. One of the most discussed topic was the possibility of the virus to invade directly the cardiomyocytes. And in the very beginning, it was believed that the virus usually do not invade the myocardium. The recent works demonstrated that because of the homology of the SARS-CoV-1 and 2, SARS-CoV-2 probably directly invades the myocardium. And the most comprehensive paper published in the end of last year by Linda and co-workers demonstrated the virus presence in 61% of the patients with COVID who undergone pathologic examination, which is an important percentage. There is a time frame between the beginning of the infection. Usually in the first 7 days, there is a respiratory phase because virus enter the superior respiratory mucosa and then fall in the inferior respiratory epithelium. And consequently, pro-inflammatory response is developed. And at this moment, usually the myocardium is involved in a easier form or a more difficult and malignant form, like in cytokine storm. What is important, and was demonstrated very, very recently, that in a very, very elegant demonstration of the outcomes by magnetic resonance imaging in patients recently recovering from coronavirus disorder, it was demonstrated that the cardiovascular involvement, as demonstrated by thickening of the wall, by pericarditis or late enhancement, is present in more than 3/4 of the patient, and in 2/3 of patient is also present a pro-inflammatory response. This is a very, very challenging problem because these findings indicate the need for ongoing investigation on long term in patients with COVID disease. There is a very known from the beginning of infection relation between the biomarker of myocardial injury, the troponin, especially high sensitivity troponin, and the prognosis. And you can see here in a paper by Zhu, published in Lancet, that in survivors, the level of troponin is much more lower than in patients who did not survive to the COVID infection, especially before the death, the level of troponin is high. And also in the papers published by others, like this one on the right panel by Guo and co-workers in JAMA Cardiology, you can see that the worst prognosis is in patients with elevated troponin and associated cardiovascular disease. What was only recently demonstrated in the patients with COVID disorder was the echographic involvement, because in the beginning, the echography was rarely used in patients with COVID. In a recent paper published by Justino in JAC, it was demonstrated that the echographic abnormalities are present in many patients with COVID. This makes us very aware that we should evaluate the patients by all means we have at our disposal, like transthoracic echography, ECG, and biomarkers, in order to establish the cardiac involvement, and this cardiac involvement is directly linked to in-hospital mortality. The second and probably the most important result from the COVID infection is a thromboendotheliopathy. You can see here that the normal endothelium has an equilibrium between anti and procoagulation, but in the diseased endothelium invaded by the coronavirus, we have both an increase of the inflammatory cytokines, but also because of the increased expression of the P-selectin, we have a demand of many polymorphonuclears, and because of netosis, the platelets are trapped inside, and we have also a prothrombotic answer. Moreover, if we are looking to platelet, the platelets are not neutral in COVID infection because of the previous risk factors like age, obesity, or diabetes, but also because of the hypoxia of the lung involvement or because of the pro-inflammatory ulcer. We have a hyperactivation of the platelet. First of all, because of platelet bound to the trap of neutrophils, the so-called netosis, but also the platelets are also responsible for augmentation of the pro-inflammatory response, and there is an increased platelet clearance and consumption. So we have the both sides of the sword, the prothrombotic and also the anticoagulant, the hemorrhagic side of the problem. As you can see here, the coagulopathy in COVID is a very difficult situation because it resembles many known syndromes. It resembles the thrombotic thrombocytopenic purpura because of the depletion of the so-called ADAM-TC13, which is a metalloproteinase, and because of this, we have an expression of the von Willebrand factor. Also, we have in common with hemolytic uremic syndrome, a dysregulation of the complement system, and finally, as common in the disseminated intravascular coagulation, we have a consumption and at the same time an increase of hypercoagulation. This makes the hypercoagulability or the hematologic consequence of the COVID very severe. We can have the signs as we have encountered in thrombotic microangiopathy, in anti-phospholipidic syndrome, in hemolytic uremic syndrome, or in hemophagocytic syndrome, and of course, as it was believed from beginning, in the so-called disseminated or septic inflammatory syndrome. So it is a very complex coagulation. Moreover, we have also important contribution of the regulation factor of adaptation transforming maladaptation, because as you can see in the normal state, the macrophage is activated by the protein S. The protein S has an inhibitory effect on the macrophage in releasing inflammatory and immune factors. During the COVID, we have a disturbed equilibrium with hypercoagulation intravascular, consumption of the protein S, and because of this macrophage become activated because there's no place for inactivation by protein S, with releasing of cytokines, and at the same time extravascular hemorrhage, which is in fact a basis for the severe lung manifestation in COVID disease. There are a lot of challenges associated with COVID myocardial infarction. In fact, we have no clear image about the number of COVID-provoked myocardial infarction. And this because we have a lot of mechanisms explaining the increase of COVID. I cited only several, like atherosclerotic plaque destabilization by inflammation and production of the type 1 myocardial infarction, or in the face of limiting fixed atherosclerosis and hypoxemia, the type 2 myocardial infarction. We have also endothelial dysfunction, which is responsible for MINOCA, for myocardial infarction with no obstructive coronary arteries. We have angiotensin II mediated vasoconstriction. It was demonstrated in many patients, and it was also in case in our hospital that many patients with STEMI of type 1 myocardial infarction had only intravascular thrombus and not critical obstruction. And of course, we have a lot of missed patients because of so-called type 3 myocardial infarction, when the sudden cardiac death provoked before we had the possibility to evaluate the markers. We have a lot of difficulties in differentiating by troponin myocardias and injury in the setting of the systemic inflammation, fever, and tachycardia. And last but not the least, the contribution of so-called treatment of the COVID-19, especially in the first part, when very few studies provoked a very disappointing opinion, because as it was said by Hippocrates, primum nocere, first of all, do not do harm. You can see here that all the substances used in the treatment of the COVID-19, even now not confirmed, have important influence of the usual cardiac drugs and also cytotoxic effect. And lastly, dear friends, I'll talk very few about arrhythmias, even this is my preferred field. We can encounter, and it was demonstrated especially in the end of past year, that in COVID there is an increase of all arrhythmias, including supraventricular and the ventricular arrhythmias. And there are many mechanisms for this, including hypoxia, including direct involvement of the myocardium, including myocardial strain, electrolytic derangement, the role of drugs. The hydroxychloroquine is very known, the intravascular volume imbalance, and myocardial ischemia. And we have here a very simplified schema demonstrating that there is a link between arrhythmias and coronary syndrome in patients with COVID. An important contributor is a sympathetic surge, which is responsible not only for the Takotsubo syndrome, stress cardiomyopathy, but also for arrhythmias. What is maybe amazing, it's a recent paper published by Catherine O'Shea and co-workers from United States in nearly 6,000 patients with ICD implanted, with more than 16,000 events, demonstrated a dramatic decrease of the events as related to remote monitoring. And this is probably linked to the lockdown period in many countries with less stress. This is interesting. This is probably the only benefit we had from this severe infection. On the other part, a very nice paper as presented by Sultanian and many co-workers from the Swedish registry demonstrated that 10% from out-of-hospital cardiac arrest and 16% from intra-hospital cardiac arrest are patients with COVID. And in fact, COVID increased 3.4 times the mortality in out-of-hospital cardiac arrest and 2.3 times the mortality in hospital cardiac arrest. The time was running, so I need to stop here. Thank you for your attention. And I can tell you that this is not the end, and even not the beginning of the end, as Churchill said, but this is probably the end of the beginning. Thank you so much.
Thank you so much, Dr. Dan. Very nice presentations. We will come back with some questions when we finish.